guys. Okay, so today I am going to be going over some review material for my exam. So basically I'm going to be teaching you guys what we were taught in class as a way for me to review, but then also just a way to review and then keep this up for students next year. So let's see, let's pull up our document. So this compilation is about 600 slides. So basically what I'm going to do is I'm just going to kind of go over it. We're going to do an all chat. Okay, let's see, can I move this over? Okay, that's fine. Okay, can I share my screen? Okay, so the first thing is we're going to go over the pathophysiology of depression. So I really wish that I could wait time more. Okay. Sorry, guys. Okay, cool. This time. Okay, so you have mood disorders, which are by the DSM-5 classification. So you have depressive disorders and then bipolar disorders. So in this first section, we're going to be talking about depressive disorders. So basically what depressive disorders are is it's broken into about 4 categories. So you have major depressive disorder, which can be broken into a single episode or recurrent. You have persistent depressive disorder, which is also known as PDD, and the major depressive disorder is MDD. Then you also have premenstrual dysphoric disorder, which is PMDD, and then disruptive mood dysregulation disorder. So the main thing we're going to focus on today is the major depressive disorder. So what that is, it's major depression, clinical depression, unipolar depression. So basically, this is the main type of depression. Sorry, I was in the classroom. Okay, so some just epidemiology. Would be its national comorbidity risk is 16%. It can occur at any age, with the highest rate occurring between 18 to 29-year-olds, and average onset is usually the late 20s. It is a higher risk in women. So some risk factors that we want to make sure we know are that it is genetic. It can be genetic, so family history, it typically occurs in families. Females are 2 to 3 times more likely. Then some environmental factors is comorbid diseases, so like a stroke, dementia, coronary artery disease, cancer, fibromyalgia, hypothyroidism, chronic pain. Then some comorbid psychiatric disorders such as alcohol and substance abuse disorder, and then anxiety and ADHD. Also stress, which would make sense. Stress is a poor cause of everything. Some other stuff that can cause depression would be, like I said, medical conditions. So CAD, which is the coronary artery disease, congestive heart failure, an MI. You could have like Cushing's, hypothyroidism, folate deficiency, and then like in women's health. So like again, like I stated, the menstrual one is a different category of depression also. There's medications that can cause depression, so like propranolol, clonidine, anabolic steroids, isotretinoin, interferons, varenicline. Sorry, I always forget. Just Chantix. So some symptoms. So at least 5 of the following symptoms must be underlined must occur within a 2-week period. So that would be depressed mood. And then how you can remember this is SIG caps. SIGgy caps. So sleep disturbance is S. Decreased interest, I. Guilt or worthlessness. Energy loss. Concentration loss. Appetite or weight change. And then psychomotor change. and then suicidal ideation or attempt. So at least 5 of those need to occur within a 2-week period, and then at least one of the following needs to be also occurring. So depressed mood or decreased interest, which is also known as anhedonia. So then a couple other things. So you want to make sure clinical significant distress and impairment in one or more areas of life. You want to make sure you're ruling out substances and the medical conditions. So some substances can also cause the depression, as we had stated, and so that would be different than this disorder. You want to make sure you're ruling out other psychiatric and mood disorders, and then you also want to make sure that they've never had a manic or hypomanic episode, because if they've had a manic or hypomanic episode, then when they're having this depressive episode, that would be considered bipolar disorder, because bipolar depression, because there's 2 poles versus like major depression is just the sadness. So next thing we're going to go is some pathophysiology. So there's many different theories about how depression can occur. So the first one is the monoamine theory, which is decreased synaptic concentration of serotonin and or norepinephrine, and then also dopamine. And so that is the reason. So we'll get into this later in the therapeutic section, but that's why you have SSRIs, which is the serotonin, then SNRIs, which also has the norepinephrine. But some issues with the monoamine theory is that there is a therapeutic lag associated with these reuptake inhibitors, and then also we do have some new antidepressants that are working by other mechanisms of action that are working to help with depression. So this theory does have a few holes in it, because we are able to manage depression not using a reuptake inhibitor. So that's one of the holes of that. And then some more. So there's it is a dysregulated neurotransmitter system, and then with the 5-HT norepinephrine and then dopamine. So for serotonin dysregulation, some side effects or like symptoms, like you can kind of see, would be some issues with appetite, sleep, libido, motor function, anxiety, and then aggression. So I just got to keep in mind on the time, because I do have to leave about 4:55-ish my time, and it's currently 4:30, and then I'll come back on and do another video. And then that other video a little bit later, I will be using a whiteboard. So this is just me talking it out currently. So yeah. Then for norepinephrine and dopamine dysregulation, so that's where you're going to see the disinterest, or decreased energy, memory impairment, and then executive dysfunctions. So typically, that's also why you're going to see it more likely than not that there is some sort of dysregulation in dopamine and norepinephrine, because as I said, the decreased interest is one of the 2 that is required to be considered depression. So then along with, there's another one. So there can be a change in receptor density. So if you decrease the postsynaptic alpha-1 receptor sensitivity, you're also going to have a sensitization of alpha-2 receptors and an alteration in sensitivity of the 5-HT1A, 1D7, along with 5-HT2A. I'm just going to skip some more of these pathophysiology theories, because there's just a lot of them, and it's just a lot. So some genetic studies that you might have would be genes implicated in predictive response or adverse effects to antidepressants. So there's serotonin transporters, tryptophan hydroxylase enzymes, 5-HT1A and 5-HT2A receptors, BDNF, and then CYP2D6 polymorphism, which can be ultra-rapid, rapid, intermediate, and poor metabolizers, affects metabolism of antidepressants. So we kind of just went over like pathophysiology, like kind of what is depression? Like what's going on in your head and in your body that's going to be causing this depression? So the next thing we're going to have is the treatment of depression. Also, if I'm talking too fast and someone ends up watching this later, just let me know. My apologies. Like, I'm not trying to, talk too fast, but also, like, sorry. Ah, what? Okay. Sorry, guys. Give me just a second. Trying to see if there's a way I can. Guess not. I was gonna try to share it. Oh well. Okay. So, the treatment of depression. I do think I kind of want to maybe. Let's see. Give me a sec. Okay. See if I write on the board if y'all can see it or not. So if you can't, then we're just gonna skip that. Oh, you cannot see that. Okay. Let's see. I get closer if you can see it. Oh, the problem is it's not. Can I? Oh, I wonder if I can mirror myself. Dang it. I wonder if I can flip it. Customization. Guess not. Okay. Well, that theory was. Wait. Oh, you can't. Dang it. It is flipped. Well. Okay. That's unfortunate. I will try to figure something out for my next thing. Oh, I kind of want to write about it though. Okay. This is unfortunate. Give me just a sec. I don't like that it's. This angers me. Okay. Well, I'm going to come back because I'm actually going to break these into sections as we go so that these are shorter videos. So we'll be back.